Were you here yesterday?
No, I was working clinically yesterday, actually.
Yeah, okay. me too, actually. I was on call.
So once you're ready to start, this is muted right now.
All right.
You just press it once it's going to turn green.
Green. Got it.
And it's on.
Yeah, got it.
So it's muted right now until you're ready.
Great. Thank you.
So when she's done, we switch.
Yeah, you switch, yes, correct.
So this is the...
Oh, and you'll switch the mic. Well,
Yeah,
you have
so
to
both-
take the
yeah,
mic
yeah,
off.
switch
Okay.
everything, yes.
Wait, but then I don't need this. Why do I need this?
No, this one.
This one.
No, I'm gonna give you another one. So
Okay.
this is for her for when she's talking. This one here is for the camera purposes to pick up your voice.
Oh.
And then this one here is gonna pick up.
Video recording.
Yes, correct.
Oh, so she needs this. Okay.
So I need both.
Okay, got it.
And then.
Toot, 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 toot.
Do you guys need water or you have water?
I have one.
I'm good, thank you.
So I have it muted right now. One, two.
How about this? Will it stay on?
Yes, that can work.
Does it look like I have an antenna? Or I need both. Okay. Go ahead. Go ahead.
The two of us couldn't find it. There it is.
Oh. I never would have known that that was where
actually,
it
I
was.
couldn't find it. We hunted Saturday.
Are you Jennifer?
Yes.
Yes. Can I just?
Go right ahead.
produce
Do whatever.
something?
Go ahead. Yep.
This is the panel on, is it pediatric?
Yes.
International. Or
Yes.
What is the actual title? I forgot.
I don't know.
Oh, sounds just nice and broad.
Broad, exactly.
What are you doing here?
She couldn't stay away.
I told my husband, give me 1 hour break, please. And he's humorous, he's broken, but I said I need a break for 1 hour.
No pun intended.
What happened?
Yeah, I thought she wasn't going to be here.
But I couldn't miss this. I said, let me, he fell down and he has a fracture of the surgical neck and greater tuberosity
Oh no.
and multiple other injuries. And
Oh no.
I canceled my Alaska trip. I mean, so that's why when he asked me, I said, Jennifer. I said, talk to Jennifer because I'm not here, I'm in Alaska.
Oh, and
And I convinced him, I said, superb, great opportunity because she does so many work internationally. And,
when Carlos was like, I was like,
we should have invited Carlos also. Carlos,
He did, and he said no.
okay, because
He's
that
taking,
should
the baby I
have
think has
done as a team.
Coxsackie.
So I want to introduce two amazing individuals.
Oh,
Dr.
sir.
Louis Don Pierre, Dr.
Good
Benita
afternoon,
Shah,
sir. Good afternoon.
My pleasure.
director of the PICU at Brooklyn Hospital, and longtime director of the PGD at Kings County.
Yes.
And Dr.
And-
Bromberg and
Oh,
Dr.
that's
Steve
my mentor.
I,
Oh, boy.
Sarah Rostron.
Oh, yes.
They are all our babies.
Oh, my
Sarah was
goodness.
my chief resident.
No, Ken Bromberg can be your baby.
No, Ken Bromberg. No, Sarah Rostron. Colleagues. Me
I
and
know.
Bromberg and Steve I, we were
You know, he was
colleagues.
my boss for a long
Correct,
time.
correct,
Yes,
correct.
yes, yes. We still talk. Yes. Very good.
I came a couple of times to give grand rounds, almost like for the last 10 years I was coming every other year also. So, but nice meeting
My
you
pleasure.
formally.
Really, my pleasure.
So Jennifer, July 31st was my Alaska trip.
Oh.
So my everything I had to cancel, and that's why I said I wasn't going to be here.
Oh, gotcha. Gotcha.
Then we're going to just get started because...
Okay.
Good afternoon. My name is Dr. Ramon Gist. I'm the director for the PICU here at SUNY Downstate.
I'm gonna ask
welcome
everybody to
everyone
move
to
forward.
our session on challenges in pediatric international medicine.
Yeah.
We have two great speakers in our presence today. We have Dr. Louis-Don Pierre, who is the director for the Pediatric Intensive Care Unit at the Brooklyn Hospital. Okay. And then we have Dr. Jennifer Chow, who is the director for the Pediatric Emergency Medicine Fellowship at Kings County Hospital. And we had a session this morning about challenges in international medicine from the adult perspective. Today we're going to talk about that topic from the peds perspective. So without further ado, I think Dr. Chow is first up.
All right, good afternoon. I'm going to ask, so this is going to be a brief sort of intro by both of us to kind of give you an idea of what we've done so that we can start basically a discussion. So with that, can you guys move forward? Like, we'd like this to be it's basically a discussion. As far as when I was asked to do this, I was like, I don't know what I would even talk about. And I realized, as somebody that does adult education now and as a parent, you realize the things that are important to you as the quote learner are the things that are going to be important. And so if I've had experiences that don't resonate with you, you will just snooze through it, and it's just you won't get anything out of it. So what we decided to do is to give you a smattering about what we have done, and then make this into a conversation. And I definitely do not say that I am sort of an expert on challenges, but I will say that I've had lots of challenges, and I've done a lot of various things. And so even when I was kind of going through this, I realized, wow, there's a lot of different areas that you all may be interested in as far as in international medicine. And again, what I'd like this to do is just spark your questions, and so that we can discuss more. So I'm just going to tell you what sort of I've done. My role in international medicine started in 2001 after the earthquake in El Salvador, and this was when I was in my third year of residency. And basically there was significant damage there. We had attendings that were from El Salvador, and so of course when you see, the same way, I guess recently there was the volcanoes in Guatemala. You see these pictures and you're like, oh my God, I have to do something. And so that was their response. And so they decided to sort of gather people up. And this was, times change, right? So this was when you had to free luggage, like you could have luggage space. Everybody, when you bought a ticket, you actually had luggage space that you didn't have to pay for. So the idea was we would pay for our tickets, and we would use our luggage space for the equipment, the supplies, everything that we would bring down. And so with residents and attendings from Winthrop, we went down and sort of provided, quote, direct aid. After that, we sort of became a bit more organized, and we developed a 501c3 organization, put together the ability to sort of gather funds and everything and organize better. We would, of course, be greeted by like throngs of people. They were all thrilled. There was sort of like what we talk about is this piñata effect. There's free stuff. I mean, we have it here, right? Free stuff, everyone comes. And so we would have lots of people waiting for us, and we would sort of provided a lot of, quote, direct care. They would sit and they would wait for hours and hours and hours. It would be hot, and it gave me a real appreciation for what people do and don't have and what people will tolerate. And so there was a lot of stuff that this taught me. But after a while, we realized that only so many, especially with pediatrics, right, there are only so many people that are sick at a time. And we would also extend our reach at times and be seeing some adults, which was probably a little more than many of the people that had done pediatrics was, you know, is within our realm. Again, we would bring down lots of medications. We would set up our own pharmacies. So these are the types of things, again, if you've had issues with these that we can discuss, like how do you get medications, how do you bring them down? Again, times have changed, especially nowadays with airport security and everything. But at that point, you could throw a lot of stuff in your bag and bring stuff down. We also used to have a lot of donations from, what do you call it, like the representatives. And that said, a lot of the, once we had organized to do fundraising and whatnot, we also worked with places like AmeriCares and Catholic Charities and medical missions, and you could actually buy in bulk sort of low-cost medications. And so sort of slowly and slowly, there became more organization and form to these trips. Again, there was this whole other side of things, and that tends to come along with international medicine, which is fundraising. That was a whole new adventure, right? It's something that I certainly knew nothing about, and honestly was not very good at. But you know, almost party organizing. Then at one point we had also partnered with JetBlue. JetBlue actually services their planes or they used to service them down in El Salvador. We would carry the people and then be able to use their cargo space for lots and lots of stuff, and we had lots and lots of donations. So again, you can see there's lots of obstacles that were met and some that were overcome, but again, please think about things that you want to, that may resonate with you and the issues that you've seen. We use this model, the group, we actually named it Pediatricians for Central America's Children, and we sort of replicated this model in Guatemala and Dominican Republic, and in various places in El Salvador and actually in Honduras as well. One of the other things that tended to be a part of some of these trips was sort of visiting hospitals and bringing mostly supplies, because again, that became, especially because we were working with the residency program, an education component. And again, every time you would bring people down, it's just an eye-opening experience coming from here where we have the land of plenty to a place like that, you know, where we just felt like you wanted to give them everything. So what we would do on those sort of visits would be sort of exchange a potentially eye-opening experience and sometimes some education with some medical equipment that had been donated. So as things had gone along, we realized, well, you know what, there's only so many kids that are sick in a day. We may actually be causing more harms than good by bringing these medications that they may not have long-term access to, again, with the adults, things like blood pressure medications, diabetes medications, and then even with the kids, as far as smattering around antibiotics and this and that, are we just causing, you know, we could be causing allergic reactions, we could be causing resistance. We're not there all the time. So we did partner with a group called Manos Amigas to help build a clinic. This clinic was called the Clinic Miraflores, and that is actually the clinic down there. And with funds, we would help to supply money for hiring a doctor and then some continuous supplies. The nice thing about Manos Amigas as well is they worked with this one community to try and help them become stronger. This is their workshop where they would make things that you could find in the airport, like the gift shops, and they would work in produce these little trinkets and whatnot, and they would have an income. The problem with this is in El Salvador, there's lots of gangs and whatnot, and this also became somewhat of an attractor for some gang activity. So again, challenges. If this is something that you've seen, there's the good and the bad of doing a little better. So looking around and trying to figure out what else we could really do to make an impact if we just come down on these sort of spot trips, we realized like this is their kitchen. This is like a regular house kitchen, right? So dirt floors, wood, cooking, so you have smoke, asthma, lots of just health problems just from hygiene. And so that kind of changed our model once again, and we went more towards public health, and we partnered with groups called like Living Waters, which help put in, it's funny, I want to say that the Spanish, it's un pozo, a well next to the clinic, and they actually put 2 wells in this community so that they could have more access to clean water. And then it was, often we would take these sort of gatherings. Again, I showed you how lots of people would come because, you know, here come the American doctors and their stuff, so they would come and spend the whole day there. And we would try and use that as an opportunity to do just sort of some basic education, thinking about the types of primary care things that we do at well visits, you know, talking about hygiene, talking about brushing your teeth, talking about washing your hands, covering your cough, things like that. So I realized too that my path has followed my career here as well. And so after I joined here at Downstate, and with sort of ultrasound becoming a part of my practice, I realized that ultrasound in the third world can be huge. You know, not only is there no radiation, but the cost and the reusability of it makes it a terrific modality for them. And so I sort of forayed into working with the Children's Hospital, Benjamin Bloom, which is the only children's hospital in El Salvador. And through donations, we were able to get them a Sonosite 180. So I don't know if this is the Sonosite 180. It is, it's funny because we're going down back to these tiny little things, but tiny little things with a lot more resolution. But this thing is still working about 10 years later, and they're using it. So basically by giving them some equipment and then training, we've helped them sort of start an ultrasound program. So there have been several trips that we went down there, and we did like 2-3-day education sessions. We partnered with them as well as one of the sort of more rural hospitals where we had a connection, where we had a radiologist that was interested in sort of bringing this to the emergency department. And they also had some other equipment. So he was interested in training the emergency department. And so we did several courses over the years. And yes, welcome is spelled wrong. But I didn't realize until I put it up. I was like, oh, that's kind of endearing. Again, we would get loaners. So again, things that, like, I want to hear about what people have faced is this was done a lot with Sonosite, because they were extremely generous with their equipment, and they would let us bring stuff down, and that's how we would have enough equipment so that people could really have hands-on time with the courses. As far as with El Salvador, as far as products, I also was lucky enough to get hooked up through Dr. Bohem with Simon Chamash, who was a MPH student looking for a project in a Spanish-speaking country. And he went down and spent some time in Bloom, and he characterized what they were doing with their ultrasound, and then looking at sort of what are potential barriers. And out of that came, he got 2 posters out of it, and of course his MPH thesis. So the last thing I want to share with you is the project that grew out of that, which was through Benita Shah, which brought me to India. And Dr. Shah was organizing a pediatric emergency medicine review course. And so I went along to help do some of the lectures, and then also sort of give this same course to the providers there. So it kind of gives you an example of once you've sort of got a setup on sort of a program, it's kind of easy to potentially bring to another country. so the last thing I want to share with you out of that is that this too produced a work product. And so along with the folks down in India, we were able to get a publication out of this. So you can see there's a lot of different things that I can sort of speak to again, and I'd love to have a conversation with you all and what parts of this you might be interested in. I certainly do not proclaim that the end result is by any means the right or the way to do it. And so I'd love to hear sort of what you guys have been doing and how we can kind of troubleshoot. All right, what did I do to myself here? Let's see. You can pull. Okay. Thanks.
I'd like to ask you,
Yes.
When bringing ultrasound education to El Salvador, how do you deal with challenges of making sure that when bringing your ultrasound practices, making sure that the images are read correctly and
Yeah, so as far as like review type of stuff, that's the question. So that's one of the places that we were not terribly successful. One of the things, there is literature out there about sort of photo tape review and that works. At the same time, we had not done that, and that was part of how we did deal with that in one of the hospitals, is that the radiologist was on board. And so the radiologist kind of said that he was going to be their overseer. That's definitely one of the places that we did not come up with a good resolution. But now I think even more nowadays that if you were able to upload stuff, and if you are doing it within a division, like an ultrasound division, that you could probably just add it in to like your tape review day and just make it a routine. And that's part of what Simon also did was, looking at the challenges. And it's very interesting. They face the same types of challenges, like sometimes radiology isn't that on board, access to machines. It's very similar types of things. But it's a very important thing that we need to do. That said, what we're going to do is we're going to have Louis give his presentation, and then we're going to have more discussion after that.
Thank you. Thank you for having me. My name is Louis Pierre. As you can see, I'm the director of Pediatric Intensive Care at Brooklyn Hospital. Believe it or not, I've been doing it for 20 years already at that same location as of July, so I'm quite proud of that. But what mostly is interesting to me in my career is what I do in global health, really. I'm also the president of this organization called Pulse Pediatric Universal Life-Saving Effort. And what I intend to do here is tell you a little bit about the little bit of reading that I've been doing about the implementation, and then going to the journey that we've entertained with global health and how it plugs in all together. My first disclaimer here is that I'm an eternal optimist. I believe in the good of everything, and talking about challenges is a little bit difficult for me because I'd rather think about the solutions, about how we can make it happen instead of talking about the problems. However, one needs to be mindful about what the challenges are so that we can move forward. So let's go with it. Please bear with me. I'll have time to sort of show you what we did as well. But I just wanted to share with you a little bit about what implementation is all about. Because our thing, starting with Pulse, is we organized in 2010 with a nonprofit organization, and our idea was to basically develop pediatric intensive care pods in areas that were underserved. I am from Haiti, so we started there. And my global health involvement started perhaps 10 years before that, where we would go on missions and we came frustrated. And the best way to put it is you come back home and you feel like you've dropped one into the bucket, and it didn't make a big difference for the environment. Of course, you come back accomplished, but that was still unsettled with me. And very interesting enough, it's an earthquake that took shaking of our thinking to change this. The earthquake in Haiti actually was the impetus for us to start our organization called Pulse, whereas we said, you know what we saw couldn't be helped by only primary care medicine, but there was a role for intensive care medicine in that area, in that realm. So therefore, I appreciate the fact that you mentioned that an earthquake actually mobilized people to do something. So just not to bore you too much, but what I've understood now is that implementation basically has several wheels that are turning around to make this, again, that's a buzzword that we all use, sustainable, and how to carry this out. So of course you have here the red wheel where we think we need to have a practice that we're bringing about that needs to be effective, right? But of course you need to be mindful of the conditions where you're going to put that practice in and the critical factors that actually make those wheels turn. So the challenges that we have seen, or that I have seen in my colleagues as well, are let's make this real life for the location where you're going to implement that practice. What some of us who do global health may not realize is that sometimes it's not right to transpose a certain level of care to a different locality. For instance, practicing intensive care, how we think it here, is not real life over there. So therefore, one needs to be mindful of that. So my philosophy perhaps is, let's see what resources they have and implement intensive care with what is available there. I'll give you an anecdote that or not an anecdote, or an example that I often use. If a mom is providing hydration for her kid every 15 minutes with a spoon, for me, that is intensive care. I'm bringing it down to the simplest way of providing intensive care, but that is intensive care. And that perhaps would prevent shock, dehydration, and death even. And again, talking about earthquakes, we often work in chaos. So these are some of the challenges that we face. It's usually a chaotic environment when you're trying to provide what you think you can do here, over there. And of course, it requires a lot of leadership. Not necessarily from us bringing what we think we should bring over there, but you need to identify a stakeholder or a champion in that location to bring about change as well. And of course, it's without saying that there are communication challenges with different languages and to make transitions in terms of what you're going to bring to them. And of course, there's community dynamics that makes it challenging. So what I have realized is that there's a science of implementing stuff that's not only relevant to medicine. Actually, it's not yet so relevant to medicine perhaps, but to every other disciplines in terms of knowing what are you going to implement, who are you going to implement it for, and to whom, and for what, and where. So as you're determining that practice, those questions need to be answered. And of course, there are many drivers, things that are going to bring it around in terms of implementing policies so that this can come about. And of course, policies, procedures, you need to teach, you need to coach people, and that's without belaboring the topic, that's what's important. So this is what I call the chain of implementation. As you can see here, first, you need to identify a problem. That's what we're talking about here, the challenges. So therefore, the problems can be numerous. I've just listed a few here in terms of resources and quality, perhaps. Second, you need to determine what causes these problems. Knowledge can be an issue. That's why we sometimes go into educating. And of course, we need to be mindful of cultural problems as well. And of course, developing solutions. That's where I actually spend most of my time in terms of finding the solution to these problems in education, in training, etc. Lastly, how to implement those interventions. And here are some of the things that you've heard already. clean water, vaccination, and of course, bringing a sonogram into an area that doesn't have it. Or for me, CPAP, for instance, would be something that you would want to implement. So what I'll do next is briefly talk to you about our journey with our organization in terms of few clinical practices that we were entertaining to implement, and perhaps that will bring about more questions about how we did it. Obviously, bubble CPAP doesn't require a machine, so it's a low-cost, low-tech device. So from 2001, Dr. LeBlanc, a neonatologist that works at Brooklyn Hospital, actually is a graduate of Downstate as well. We were the two of us going to missions in Haiti, trying to create some change. And again, the fact of coming back and feeling that we just dropped in the bucket once was unsettling to us. So it took several years, really, for this to be, to take some traction. So basically up to 2010, after the earthquake, this is when it really started to make a difference, because we brought the CPAP. People would actually, the next time they would go back, we would just see the CPAP machine or the CPAP device in the cupboard full of dust. So basically this is the area, the time around the earthquake. Of course, it looks very chaotic here. There are two babies here, and this was the only structure where people would actually be able to be inside, because of course after the earthquake, people didn't want to go inside the building, they would stay outside. So that was the only functioning hospital. And believe it or not, these were the first two monitors in that hospital, except for the operating room. So we brought down 3 monitors and kind of said, okay, let's create an ICU so that we can work. And of course, we brought down the bubble CPAP as well, and this was the first baby in that location that ever was fitted with a CPAP. And as you can see here, it's not just like the CPAP that we know here, which is a bit more refined, but certainly this baby was able to be saved and, with that device. Several years later, what we've done is brought in a course we call Pediatric Fundamental of Critical Care Support. That course basically intends to raise the ability of a person who's not an intensivist to stabilize the patient for the first 24 to 48 hours until help would come. So we said, well, let's take that course and train folks in those areas. And of course, that was a good instrument to sort of help people bring their knowledge and their abilities. Mind you, that course did not have bubble CPAP in it. Obviously, because we're intensivists, we think about ventilators. But in that context, in that country, or in Haiti at this point, bringing a ventilator would actually be deleterious, in my opinion. So we were able, in that lecture for respiratory management, we brought instead the bubble CPAP. And that was around 2002. And as of now, I can tell you that almost every hospital that you go into Haiti right now, you speak to residents, they know about the bubble CPAP and they're actually doing it. So I think this has perhaps made a big difference and improved some outcomes, although they're not really well measured in my opinion yet. So again, these are some pictures of the residents and attendings that attended the course and actually were certified by the Society of Critical Medicine with our efforts. And again, as you can see here, we did actually bring a ventilator, but it was a portable ventilator that you guys are familiar here, which we don't use really for the hospital, but perhaps that if a kid needed a ventilator for 1 day or 2 days, you may use it, but that wouldn't sustain a person who would be sick on respiratory failure, etc. So again, lots of limitations and perhaps lots of ethical questions as far as who you would choose to bring and put on that respirator. One more anecdote about the Manenhar incubator. This is something that we've seen in Nepal, in our trips to Nepal. Basically, because we were doing this in Haiti, another house staff or resident who was Nepalese invited us to do the same in Nepal. So that's why there's a replication of what we do here. So nevertheless, when we went to Nepal, we saw that incubator that was actually copyrighted, if you want to call it that way, by Professor Mananda, who was quite a visionary. So he basically partnered with the engineering school, and they devised a wooden box, you can see it here, with light bulbs under it, which would maintain the temperature of the child, and that basically became an incubator. So what we thought is perhaps, that's Dr. Manandar here, perhaps if we were to replicate this, perhaps we could make it happen in Haiti as well, where resources are quite limited. However, that box that we replicated, of course, mind you, some of the residents from Haiti, what we've done at Brooklyn Hospital actually is have them come here for 3 months as observers. So one of them was interested. So he saw the box, we showed it to him, he made it happen, he found somebody to create something that's very similar and a little bit more, how should I say this, polished or whatever you want to call it. But by the way, that box is still in his library, has never been used. And these are some of the other challenges. Why? Because perhaps people that are used to seeing 1 or 2 incubators that you see in the developed areas, it was not so appealing to them. So perhaps that could be a reason why it wasn't really used. So again, it didn't take traction perhaps. So what we've done also is, before we sort of delved into the work of global health, we thought maybe we need to assess the situation and see what's going on here. So what we've done is through surveys, we've questioned people that work in all the hospitals or most of the hospitals in Haiti, and we're able to publish several papers about assessing critical care in those areas, both in Nepal, in Nigeria as well, where we have some work doing. And we've been also able to sort of do some in Haiti as well, which is my home place. And lastly, what we've done is try to compare from right after the earthquake and 5 years later, what's the difference? So what I can report to you as far as this paper that we published in the Society of Critical Medicine is that if you see the first 5, these are the major areas where we've been able to sort of show a difference. And if you can see here, for the less than 30% of the hospitals were having regular basic life support. Mind you, this is 2 years after the earthquake, 2012. And 5 years later in 2016, there's at least more than 50% increase in both that and blood bank services. People were now understanding that there's value to teaching for neonatal resuscitation PALS, and the number of monitored beds increased significantly. So this was for services. As far as equipment is concerned, a significant amount of change has happened as well. More hospitals were having x-rays, ABG kits, mechanical ventilators as well, and syringe pumps. From the time that we started working in Haiti, there were no such thing as syringe. But just imagine if a kid came in with DKA, there would be no way of placing him on a pump to treat his DKA. So basically, the visual drip system would be what's available. So again, lastly, what I'd like to leave with you is that we cannot know exactly what the right model for a certain location would be, but there's a lot of issue about adaptation so that we can make this sustainable. And of course, funding is everything, because it requires a lot of money and funds to get this going, and who would be the payer for that? And of course, it requires a lot of flexibility from people who actually want to do global health and what we do, and of course, lots of patience. I like to show that picture to people who do global health and resource limited areas. If we were to compare where we work or where I work, which is the United States, we don't have all these resources here. So are we resource limited? So lastly, because I'm an intensivist and we intend to develop intensive care in those areas, the thought needs to come about as far as. So my thoughts are, perhaps if we regionalize what we do and not do it everywhere in a certain country or location, that can be better. And of course, we need to sort of have a database of all the assets that are, and the assets don't mean things, they also mean people, stuff, staff, and places. And of course, measure the outcomes, and that's essential. And basically, that's how we can actually publish more about what we're doing. We need to have integrated transport system to come to this hub, and what we in our organization like is we call it a hub and spoke model, in the sense that you determine which hub you're going to use and have a transport system that brings about patients to that location. And of course, in my opinion, education and training is key. And whether we develop a fellowship program or master's program through telemedicine or et cetera is to be determined. And of course, leadership is something that's important. And here I'll show you very quickly some of the pictures that we've taken with some of the leaders in that location. For instance, this is the dean of the medical school, the chief medical officer. We're taking pictures with them. So you have to sort of speak to those folks so that things can be changed. And in Nigeria, we did also have an audience with the emir of that state. So when people start to see what you're doing, perhaps that can have some impact, hopefully. And lastly, teaching, coaching, that's where I think we can sort of bridge the gap, because as you're teaching and coaching and developing programs, you can perhaps raise people's attention to things that they didn't know, and as you research, as you do all of that, then perhaps you can bridge the gap with all these problems in implementation. And this is us here in Nigeria, in El Salvador as well, and Nigeria again. And one last thing is that some of our teachers actually are ex-residents, and also these are residents that are locally being trained, so trainer is also something to implement. And this is here Dr. Pinto, who's part of our organization. He's one of the intensivists here. And lastly, mentoring and having folks publish also from the locations is also essential. So this gentleman here is a nurse who was able to sort of publish a paper about his needs assessment research. And lastly, I'll leave you with this picture with one of the largest courses of PFCCS that we've done in Haiti. And this spot here in the left lower corner, that's my spot. I didn't have time to run to the camera yet. So, and lastly, this is a pitch. Please like us on Facebook. And our organization is Pulse Now, so Pediatric Universal Life-Saving Effort. So I'll stop here, and if you have any questions, we'll entertain them. Thank you.
All right, so what we'll do now is have Dr. Chan here come sit up front, and we will open up the floor to questions. I'll come around and I will pass the microphone. So, do we have any questions for our panelists?
So I have questions for you guys then. I guess, how many people are involved in sort of direct care types of things? Or like have gone on trips that, you know, you are the on the ground, the hands to the patient type of thing? And then how many people are involved in more sort of the organization and funding end of things? And so I'm going to ask, I'll pick on you. Can you tell us a little bit about what you do and what you are finding some of your challenges to be?
Sure. So I'm Manish Garg. I'm at Temple University Hospital in Philadelphia. Can you hear me?
Yes.
Yeah, okay. I am going to be the president of this organization. Yeah, at 2 o'clock in 45 minutes. So at Temple, I've had a few different roles. So I lead our efforts in terms of getting students, residents, fellows, attendings all over the world. So both with direct patient care as well as with leading and trying to direct folks. As I've seasoned in the dean's office and as I've gotten more mature in terms of planning these, I've transitioned from direct care to more like educational capacity building to, you know, supervisory roles. My challenge is with students is creating all of the satisfactory trip planning that is required to make sure that A, the students are safe, or well, the whole thing, students, residents, faculty, fellows, that they're safe, that they have operational assistance, that their experiences are educationally valid, you know, and so it requires a lot of vetting. It requires making sure that I'm always checking the State Department website to make sure that, you know, to see if a place is category, you know, 1 or 2, level 1 or 2, or whether it's kind of been bumped up to 3 or 4. The policies that we've created is say that you can't get somebody up to a, if it's 3 or 4, they can't go. And that just happened to us in Nicaragua. We had a group that was heading out there, and all of a sudden there were riots, and they went from a level 2 to a level 3. So that was a huge problem. Similarly, we just had a Nipah virus outbreak in Kerala, in India, and so I had a group going out there, and thankfully, because of Sagar's great INDICM, you know, spoke model, we were able to go to a different site out there. So I learned that you need to have flexibility with the partnership program to make sure that they had multiple sites. When the first time I was working with Global Medical Brigades, Honduras, when it got bumped up to a level like 3 or level 4, then we moved to Nicaragua. But now Nicaragua got bumped up, and then they didn't have a backup plan. So you know, there been a lot of successes, obviously, through this process. I've been able to create documentation. I've been able to validate a global health curriculum. I've been able to find ways to share my work, and certainly anything that I do is available to all of you in terms of helping me to be able to establish these programs and to be able to make sure that, you know, these outfits are running safely, you know, with good education, that the operations are going well, and whatever I can control, I can control.
It's very interesting. I mean, first of all, you should have been up here, not us, but.
Yes.
You know. But it's very interesting that you bring up even as far as the issues for the different places as far as keeping people, quote, safe. I'll tell you, honestly, for me personally, and this comes into as far as different people going places personally, like I haven't been down to El Salvador for a bit now because I just had a baby. So that whole, you know, Zika. And so it's a very interesting, you know, hearing that thing on a bigger scale.
I have a question. Do you, we have a large audience of practitioners who care for adults. Do you think that there are unique challenges in establishing programs that focus on caring for children that may be different from caring for adult patients, or educating practitioners about adult care?
I think so. I think the challenges are, you know, not so unique to pediatrics, but what I find is that when you go out there as a pediatrician trying to make some change, first of all, you find, you know, counterparts or people that do pediatrics as well who are interested into what you are doing as well. But my sense of this is that for pediatrics, it's always the stepchild of things, okay? People are usually not interested in pediatrics. And I'll speak for where I'm from. I'm from Haiti. And where they care for pediatric patients doesn't look anywhere near where they care for adults. At the government level, in the government hospital. So those areas that have something that, you know, looks more like, more representative of what we all used to hear are done by NGOs. You know, not necessarily by the government. So these are some of the things, some of the challenges that I've seen that are, you know, inherent to pediatrics per se. And there's a lot more effort and there's a lot more twisting of the arm and speaking to people who are responsible to sort of get them to the realization that children are the future.
So yeah, for my experience, has been equipment, training, have been real problems. So every time I find like a pediatric ambu bag, you know, the problem is that the rest of the world is set up for adults.
Yes.
And all of the equipment is adult equipment because generally that can be a one-size-fits-all equipment, and you can mass produce that easily. But to have something specifically for an infant versus a toddler, very, very different. And so every time we try to donate supplies specifically to hospitals and emergency departments. We just donated about $17,000 down to Puerto Rico, the hurricane effort. But if in Haiti, you need, it's very easy for me to ask my hospital and our supply and operational group if there's equipment that's either unused, not expired, but unused, could we get that down to you folks? And so, these are things that I've found that they cannot, they can't live without. And, even IVs, even, everything for the kids. It's crazy.
So it's very interesting that part of the issue with that and why that comes about, I think, is because the whole issue that most kids are generally healthy until they're not, right? And so that's why we even here have stuff that just sort of expires on us that doesn't get used because we're prepared for them with these emergencies, but the way that these endotracheal tubes expire, that they probably don't feel, it's not cost effective. The one good thing I will say from at the other end, as far as asking for money for kids, that sort of touches people's hearts a little bit more. It's a little, you can kind of
yes.
grovel a little more. But I think it was that sort of realization too that, because that stuff needs to be sustainable. When you're training people with this sort of complex equipment and then they all of a sudden don't have it, because it's size related, those are bigger issues. And then I think that's sort of why we had at some point turned more towards basic education, like how do you do more, it's not as fancy and not as glamorous, but again, what do we do as general pediatricians in our well checks, and why are, to kind of do the basic, not so fancy education. So.
If I can add to this, the mindset of an intensivist, some of us, we go into this thing because we're running away from the clinic kind of thing. And my frustration with going on missions was when I felt that perhaps when I'm present and trying to work in the clinic with them, I was learning more from them than actually imparting what I knew as an intensivist. I'm talking for myself. So that's where we sort of, segued in terms of when we saw the earthquake and what we could do as intensivists. Basic. Now, I'm not talking about bringing ventilators and doing all that stuff. It's training, teaching, and teaching, and teaching again. So what we entertain doing, and as some of the slides of meeting with these people, basically that are in the leadership, is trying to develop a fellowship program in Nigeria where if perhaps for a couple of years, you could develop that program and graduate a couple of PICU fellows, put it that way. And we're calling it a Master's in Critical Care program right now. In 5 years, those would be the teachers of others. So perhaps that could help sustain those programs. So again, I really believe in the training and teaching. And that can actually solve a lot of the problems in between as you're teaching and training.
Hi, my name is Hamid Chamdawala. I'm a peds emergency medicine physician. One of the challenges I have observed when working with the pediatric population, especially in some of my work that I've done in India, in rural India, is that you sometimes have to go to where the kids are rather than expect them to be brought to you. So, some of these screening camps and screening hospitals that I used to work at, if the parents are minimum wage and have to work every day in the farm, it's really difficult for them to actually bring their children and miss a day of work, just to get screened or checked, especially if the illnesses are, non-emergent. So what we found was that, you had all these steps in place, all these training, all this equipment, doctors, but we weren't getting much of a big turnout. And that just goes back to the importance of then coordinating care with the local schools or the local centers where you can actually go and find these kids and screen them, and so that's one challenge and something that's unique in pediatrics, because again people don't think it's that important, getting a child checked and routine checkups. So that was something that I had noticed when I was working in some of these rural communities in India.
I'd be remiss if I didn't give Dr. Benita a chance to give her perspective on international pediatric medicine.
I salute, because what they do, of course, it is much more challenging than what I have been involved for last about 8 years in India. And my role is focusing on education and training. So just that's why I wanted to make a comment. So through the Indus started this about 8 years ago, and for last 5 years we have started training pediatricians, focusing on pediatric emergency medicine. And I wouldn't call that as a fellowship, but like a pediatric emergency medicine course which we have started online. Approximately about 100 pediatricians who are successfully, very successfully accomplished pediatricians, meaning like board certifications in pediatrics, equivalent to MD pediatrics here. They have enrolled in this course for last 5 years, and they have successfully completed 12 months training online, monthly reading the textbook of pediatric emergency medicine, taking the examination. So we created the examinations, meaning Jennifer and her, all the pediatric emergency medicine at downstate, all the fellows. Again, so we were not only educating pediatricians in India, but we were also educating our faculty, acting as a role model, and our fellows, because we were also making them an educator, because they started writing questions for these exams. And so from this institution, from downstate and from Detroit Children's Hospital, Prashant Mahajan, we coordinated two institutions, and everybody, all the fellows in pediatric emergency medicine and faculty got involved, and we created 12 examinations and one final exam. So we have now close to about 800 questions created. And so these pediatricians from India who are MD pediatricians are enrolled in this course, have successfully completed this course, and to because this is just a theoretical knowledge. So to bring practical knowledge now, for last 5 years, I have gone to India in different cities, and all those pediatricians come and take this practical board review plus practical hands-on experience. Mm-hmm. So as a part of that, it's a 1 week emergency medicine course, and part of that is not only lectures but also every afternoon workshops, which includes ultrasound workshops, sutures, splinting. So just to give you a little flavor of that. So that's what I have been doing for last 5 years. And so this is training and education aspect. And I would not call fellowship, but something similar you can also implement in a critical care.
Oh, absolutely, yes.
We have time for 1 or 2 last questions. We're coming to the end of our session.
Hi, I'm Jennifer Tobin. I'm actually an internal medicine hospitalist, but help to coordinate trips to the rural part of the Dominican Republic and to a community just outside of Port-au-Prince that we've been working with for many years now. And this may be a little self-serving, so I apologize, but to share a challenge that we have is actually at a very beginning level. If we struggle to recruit pediatricians to come with us. And I don't know if that's something that other people encounter in their experiences or not, and maybe it's because we send multiple teams throughout the year in order to provide continuity and continuous support, but that's actually our biggest struggle at this point. It can't even get to the education and help with training and whatnot, is the actual recruitment of pediatric trained practitioners to come with us.
I unfortunately will say that I've had the same experience. Let me speak for our organization, because our thing is more specific to, okay, we're going to do a course, we're going to do the PFCCS course, and we do it multiple times. It's easy to find the players because we are all integrated. But I've had several organizations similar to yours who have actually reached out to me because they know that I go to Haiti several times, looking for primary care pediatricians because they're not able to find one. So I'm not sure what's creating this problem, because there's a lot of global health going on. People are quite aware of this mission, but it seems that there's a lack of pediatricians interested in providing Maybe I'm wrong.
I think it's the institutions.
And I think I agree. I think it's where you're looking.
And that's why we wrote our consensus statement, because the love is there.
Yes.
The problem is that institutions say, okay, if you're going to be gone for longer than 1 week,
Vacation.
Yeah, it's your vacation. And if you're going to be gone for 2 weeks, then you owe me a week of RVUs, right? So your problem, the problem that we all have is that McCain, one of the things we're trying to do, and this is through Stan's great vision and leadership and embodying all of our work here, we're trying to give credit and to show chairs and deans that yes, this work is valuable because it builds reputation. This work is valuable because it builds scholarship. This work is valuable because there's potential money and grants. This work is valuable because it meets the mission of the hospital and our communities. And so that's what needs to happen is we need to go into the deans and make time for our great pediatricians to get out there because they want to be out there.
It's interesting though, because the same limitations that internal medicine practitioners, not like internal medicine, they're like, of course, we'll give you time. All are up against the same trend, which is still a problem without a doubt. But it's just curious to me why the surgeons that want to go, internal medicine, family medicine that want to go, but deans, there seems to be.
We're going to have to stop at that comment because we have. Oh.
PEDS is involved in international medicine. Only thing is, if you go to AAP meetings, there's a special section of international medicine.
Correct. That's right.
But if you look at the NIH portfolio, every third international grant has gone to a pediatrician. So if you look at the portfolio at Reporter, you see every third international grant, there's a competitor pediatrician. Or the brain grant in poverty is wiped out by pediatrics completely. So there are pediatricians who are there. Only thing is they may not be seen at the meetings and because they are involved.
And perhaps these are people that are already in the system.
Yes.
But we're looking, when you're looking for volunteers, is that what you're talking about? You don't find volunteers readily to go to mission. So maybe that's two different things and we need to explore it. But you're both right. You're all right.
Unfortunately, we have to make room for the next session. But both Dr. Chow and Dr. Pierre are available for more questions afterwards. I will turn the mic over to Dr. Aquila.
I'd like to thank Ramon for bringing such a wonderful panel here. Thank you, Dr. Chow. Dr. Pierre, and can we just get a quick picture? And then I have something way more interesting than these silly pieces of paper. Okay. Okay, so you guys, we've been handing out cards for the last 2.5 days, and everybody's going, thank you, I already have one. Well, one's not enough, because each one of them is worth a different value. I don't understand it. He has explained it to me about 10 times, but I'm going to turn the mic over to my friend who's going to give out an amazing one.
So this is the lucky session, and I don't want anybody leaving here, because including our speakers, you're all eligible. And we're going to give away some of the higher denomination cards. And in fact, someone from this room will leave with a 5,000 Litecoin Cash card, which is about $250. Okay?
Paying for your registration, paying for your membership for next year. That's the most important thing.
And another one of $1,000. And Christina has some more. So some of them will go to this session, some of them will go to later session. We do want to reward people who stick around and they attend the conference for the sake of attending it and getting the value and not for the sake of the tourism associated with that. So hence the last day is the day of big rewards. And so before we go through that procedure, and it's random, I got random numbers on that board. I'm going to count. And the person who ends up with that number gets the tickets. But the one thing that I want to appeal to everyone, and I'm sure everybody already has heard that several times, but if you want to get involved, there are lists of different committees that you can sign up for. If you're interested and say you made up your mind about joining our organization and you want to be you want to have your voice heard at different levels, including committees, put your name down on one of those cards. It's publications, it's ethics, it's legislative, it's numerous different opportunities to get involved. And for those of you who are seeking opportunities at your institutions to get credit for promotion and tenure content on your CV, those are great opportunities. I mean, I can't say enough how important was that for me when I went up for promotion and I got promoted because I had enough of these items on my CV. So I encourage you to think about it, and then once you make up your mind that you want to do it, pick one area that's nearest and dearest to your interest, to your heart, and then sign up, okay? Now, what we're going to do is the first number here is R13. So starting from each row on the right side, we're going to count to 13. And this is going to start, you know, again, every row is going to start with the next consecutive number. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. You get the you take the you get you get the 1,000 ticket. Now we're gonna go from the left now. So again, the same thing. And if we go over, then it goes back to the beginning. So it's fair. And we're going from the left. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, and then I believe Rich is 26 because you were sitting and now you're standing. 27, 28. Thank you very much. 5,000 tickets.
Wow.
All right. We have probably...
The rules of Litecoin Cash, I think you'll understand what it means. But the most important part is Litecoin Cash right now directly converts to Brazilian currency. So if you say one coin is equal to 8 cents, now I don't know how much is 8 cents in Brazilian currency, but that is direct cash for you. Now there's another technique is that you can take Litecoin, stack it, convert it to Bitcoin US dollars in the exchange. So this is free money, and we are the first organization in the world to have a cryptocurrency in our pocket. Now all will follow. So in the next 2 years, you will see everybody running after everything after they like our idea. So that's the first step, but Litecoin Cash is our official partner, and in the coming 2 years, by 2019, we'll have a huge announcement where we are trying to make Litecoin Cash as a global physician's currency. So we'll be reeling and dealing in Litecoin across the world if you are a CAIM member. And so right now this has value. I don't know how much it means in Brazilian, maybe you can tell me, but in US, one Litecoin is 8 cents, but you can't do US because Litecoin has tied up with Brazilian government. So you have to only buy Brazilian cash.
You can exchange it freely to Bitcoin, and then Bitcoin
Coin can grow to dollars, but it's a roundabout. But if you want to take a vacation to Brazil, then Litecoin works. This is a tribute to our incoming president.
Yes. Yeah, so the procedure would be to send the codes in at the same time in the same email, say that you attended our conference. Now you do need to set up a wallet. Now there is a Litecoin Cash wallet that you can download from their website, or you can use what's called a Coinomi or multi-currency wallet, in which they're basically, you know, it's like a menu of 100 different cryptocurrencies. You just click on that one, and then it'll generate a receive address. You have to, they will request that from you. It's your public address. So no one can take money out of it using that address. They can only deposit into your account using that address. It's the receive address. Do not give anyone any money or anyone your send address, which is the address of your wallet when you pay. Okay? Yes?
Can one donate this to a non-profit organization?
Absolutely. Yeah. Yeah, you can donate that to a non-profit organization. They can do whatever they would like with it. In fact, we're gonna set up soon our own wallet. So that's gonna be our.
My vision is that Litecoin Cash will become our global cryptocurrency. So all doctors traveling overseas will deal only in Litecoin Cash. We are setting up the backup right now. We had a meeting yesterday morning at 7 a.m. with all our Litecoin developers. It's a fork out of Litecoin, which is a competitor for Bitcoin. And we should have an announcement by end of the year for all our members.
How many of you have been to areas of the world where everybody has a cell phone, but there are no banks? Raise your hand.
So that changes the game.
You can transact with 2 cell phones. You can use this with a flip phone. Okay?
Once we have an announcement, we'll have a full workshop. We'll get you everything.
Yep. Time's up. Yep. There will be additional tickets given away during the subsequent sessions.
Hello? All right, guys, this is the last session of the day here. I'd like to thank everybody for sticking around. Our last session is about vulnerable population, and we're very happy to have Dr. Marlink, who is the director of the Global Health Institute at Rutgers, lead with this panel a very interesting and exciting discussion about the vulnerable population in New Jersey doing global health at home. And I'm sure every one of you guys has been working with vulnerable populations, so we hope this is interactive. Dr. Marlink will lead the way, and hopefully you'll find it interesting and stimulating. Thank you, Dr. Marlink, for coming here and leading this session.
ask us to go forward.
Yeah.
Backward your laser pointer, and then you're going to need that microphone.
Okay. Thank you, Ziad. Everybody hear me okay? Okay, so I was asked to address vulnerable populations. Pretty big topic, pretty general phrase, I guess. So I thought I'd bring some experts with me that address vulnerable populations here at home, and different populations that they'll get into, and I'll have each one of them just have a few minutes to explain their work and their issues. But I'm the director of the Global Health Institute at Rutgers, and so I wanted to first explain, and we're all affiliated with Rutgers, different parts of Rutgers, as are a few folks here from this organization and at this conference. So I wanted to, this is in terms of advertising, I guess, but I came to Rutgers about a year and a half ago, and I didn't really know what Rutgers was, but New Jersey's really invested into its state university and put, in the last 8 years, put a lot of things under one roof called Rutgers. And I don't need to read this to you, you can read it as well as I, but it's really a large place that involves 30 different schools across 3 large campuses and some other affiliated campuses across New Jersey. So what we've done in terms of global health is that we started looking at the biomedical schools first, schools of public health, nursing schools. Rutgers usually has 2 of everything. There's 2 medical schools. There were 3 nursing schools, but they fused into 2 nursing schools. So suffice it to say, there's a lot going on. And we found out, though, for global health, actually one of the schools that had the most global health faculty was not in the biomedical sciences. It was in the environmental and biologic sciences in another part of the university, not under the chancellor that does biomedical. So we realized that global health was really involved across many campuses. So we created a Global Health Institute at Rutgers, and I think that's why we were asked to talk about vulnerable populations, is that we've defined global health as less about geography than about equity. So all over the world and right here at home, there's tremendous disparities in access to care and the conditions that make good health possible. So I'm just going to jump through that. Rutgers Global Health is set up to foster collaboration across the university, but also with partners at home and internationally to improve the health of vulnerable populations. That's what we're about. Our mission is here, and that is that we improve the health of the most vulnerable populations, develop solutions to critical health problems worldwide. But when we surveyed our faculty, we were involved in 112 countries around the world in terms of education, research projects, capacity building or service projects. But we also found that a lot of taking our definition of global health, a lot of them were at home in New Jersey and in the Northeast part of the United States, addressing global health issues of inequity and access to care. Obviously, this is all of our vision is to have a world with every community is healthy and thriving. So simply put, again, to our definition of global health, not just for Rutgers, but in general, especially for our Rutgers and our Global Health Institute, it's about improving access to care, treatment, and prevention, addressing health inequities, and confronting urgent health problems that affect us all. And so that includes here at home. When we talk about the definition of vulnerable populations, I think we all probably have a good idea of what it is, but I think it needs to be defined. And this is, the simple definition is groups that are disproportionately and adversely affected by disease, emergencies, and contextual factors that threaten good health, such as lack of access to care and services. So vulnerable populations for us, healthcare practitioners or healthcare researchers, healthcare workers, this is our definition, I guess, our working definition. And that's pretty broad, could include a lot of different people. The examples are listed here, and when I look more closely at what are the examples or where is it mapped out for those of us in New Jersey, this is data by the Robert Wood Foundation, but the map really of New Jersey depicts by county, there's 21 counties, who's healthy and who's living longer and who feels healthy while they're alive. And these counties are marked, for those of you that know New Jersey, you know, the darker ones are bad in terms of health and health outcomes. We have Essex County, Newark here, and then these 4 southern counties. So these 5 counties out of the 21 really jump out as the places where the fire is. If you're a fireman, you go to these fires, these 5 counties. If you want to look deeper into specific vulnerable populations, let's say those without health insurance, we see those counties are affected, but not all the southern ones as much. But some of these northern ones have a more likelihood of having a vulnerable population that are not covered by health insurance. If you look at children under the age of 18 that are in poverty, it ranges across New Jersey, but again, those ones in the north and the counties in the south are more likely to have children in poverty, and that would obviously impact quality of primary or specialized health care, medications, access to services and preventive measures, etc. When we want to look at food environment, this is a big issue at Rutgers. We have 2 food institutes and other numerous nutrition programs and researchers. We are the agriculture school. There's one in each state. We're the ag school. There's interesting, I didn't really realize why and what ag schools were until I now at an agriculture school. But that's a side point. But what it points out is that the university is in each county with actual offices and faculty in each county across the state. And when we look at food, like indicators of the food environment, where do you have low-income populations that don't live close to a grocery store, let's say, food deserts, that is. Populations that don't have access to reliable sources of food in the last year, i.e. food security. So those, again, will have worse outcomes health-wise, and we see what counties those are, the similar counties of Newark and the Essex County and the southern counties in New Jersey. This is the last sort of area we want to touch on is vulnerable populations that are involved in behavioral health problems or substance abuse issues. And Rutgers takes care of all the prison system in New Jersey in terms of health care, and the majority of mental health services, especially for the uninsured. So these are the issues for New Jersey, for every state really. This is going to actually be part of a vulnerable population, whether you're in prison or suffering from substance abuse problems outside as an outpatient. So these are the numbers, which are quite different again in terms of counties involved in admissions for substance abuse across New Jersey. We still see Newark. We see the southern counties actually are not as involved, and we see the counties along the shore here, Monmouth County and others, again having much higher substance abuse admissions. So if you're into the vulnerable populations and you're the fireman or fire person trying to go to the fire, you'd probably be working in these counties in addition to Newark, but perhaps not the southern counties. So, you know, health is, you are what you eat. Health is where you live in terms of your determinants of outcome. So I just wanted to bring home the point that it's the same for New Jersey, for New York, for any place around the world, that is. global health and the issues of vulnerable populations are important, whether we're in Zimbabwe, Ethiopia, or the United States. So our panelists are going to touch on quickly 3 areas that they work in intensely, and they're quite different, but I think it's pertinent for global health issues at home. First, we have Kata Demesi, who's our professor and our Associate Dean of Academic Affairs at Rutgers School of Public Health. We have Sneha Jacob, who's an assistant professor at Robert Wood Johnson Medical School, but the director of HIV clinical services at the Eric B. Chandler Health Clinic, which she'll tell you about in New Brunswick. And then we have Wen Hua Lu, who's assistant professor of childhood studies, Rutgers Camden College of Arts and Sciences, and she'll tell you about her distinct vulnerable population, that is, that actually here in New York City, where she actually lives. But so these 3 are our panelists. I'm going to turn it over to them in the interest of time and have them either, do you want to talk from there or do you want to talk from up here? So I'll ask Kata to come first, and thank you very much for letting me introduce the topic. So there's the pointers right there. Oh yeah, we need to escape. Oh, that might help.
Let me just get you suited up with this.
Oh, instead of this?
No, you're going to use this also.
Oh.
So where is the slideshow?
Good.
Thank you, Rick, for the introduction, and thank you for everybody for participating in this last event. So what I'm going to do, my voice is a little bit coarse, I don't know why, but what I'm going to do in brief is we have a large cohort of African American and European American breast cancer survivors that we've been following in New Jersey for the last couple of years, and I will present a brief part of that study showing how patient factors actually contribute to racial disparities in the treatment of breast cancer. I have nothing to disclose, and as a background, probably most of you know that racial disparities in health outcomes is a major public health problem in the United States. It's important for the people who seek care, and at the same time, it's important for society who believes in equality. It also compromises the trust of the people to the health profession and can actually lead to ethical and moral dilemmas in the health profession. The IOM report, Unequal Treatment Confronting Racial and Ethnic Disparities in Healthcare, which was published a couple of years ago, documents a very troubling pattern that out of the 10 leading causes of death, African Americans have actually higher in 8 of the 10 top leading causes of death. And in addition to that, the overall mortality among African Americans is about 1.6 times higher than among European Americans, and this pattern holds true for breast cancer and for other cancers. So if you look at this graph actually shows you the comparison of incidence over time between African Americans and European Americans. On average, African Americans have about 10 to 20% lower incidence compared to Europeans, but this overall age-adjusted picture actually masks an important trend when you really stratify and analyze them by age groups. And when you stratify by age group, actually below 45 years, the incidence of breast cancer is more among African Americans than European Americans, and at the same time, among this age group, the breast cancer characteristics is very, very aggressive. On the other hand, if you look at the mortality, around the 1970s, the mortality between African Americans and whites were almost similar. So close to the 1980s, it started widening and opening up, and then the disparity actually continues to widen until now, and the mortality rate among African Americans is about 40% higher than the European American population. So what are the possible reasons for the excess mortality among African Americans? It could be differential access in health care and also in treatment, particularly related to insurance. The second characteristic has to do with differences in the biology of the cancer or the cancer characteristics. We know that African Americans have a more lethal cancer and a very aggressive characteristics with basal-like type of cancers and also triple-negative cancers. And a third possibility is differential in quality of care between African Americans and whites. And my presentation is going to focus on the differential quality of treatment between the two races. You may ask me, there are a lot of papers that looked at a comparison in treatment between African Americans and European Americans. Why do you need to do that? But the problem is there is confounding by indications in all these papers. It means they are comparing apples and with oranges, because African Americans often come late, and really it is difficult to compare African Americans with white in terms of mortality without taking into account the stage and also the characteristics of the breast cancer each of them had. So we have to really compare apples with apples and oranges with oranges by taking into account the detailed clinical picture of this disease. And the only thing you can do is the tumor registries are very weak, where a lot of the studies were based on having these clinical detail variables and characteristics. So a comprehensive medical record review from multiple providers is the only way to go, and this is what we did in New Jersey. So the aim of the study is to determine if there is real racial differences in the treatment of early breast cancer, and also to determine differences in delays to treatment in both diagnosis and treatment between the two groups. So we've been following this large cohort of African Americans and white population for the last 15 years in New Jersey. Actually, it is one of the 3 largest cohorts of breast cancer survivors in the nation. The only comparable cohort is from the Carolina breast cancer study, and the one in Boston, the Black woman study, are the only comparable to our study. And our study is called the Woman Circles of Health Study is the name of our study, if you look at it in the literature. Basically, our aim, we are close to 1,700 women now, but we continue recruiting these women, and we continue following these women who are survivors of breast cancer. And we worked with the cancer registry, which is under the Department of Epidemiology in the School of Public Health. One of very rare conditions where Rutgers has the tumor registry under the university, similar to University of California. Probably 2 universities have that type of representation. And we use a rapid case ascertainment methodology. Immediately when patients are diagnosed, their information goes to electronically to EPAD report will be sent to the tumor registry, and immediately we recruit them and do home interview on these patients. And at the same time, we obtain the names of the providers and get medical records and review the medical records of, the general practitioner, or not the general practitioner, the primary care physician, the medical oncologist, surgical radiation oncologist. So we have a complete information, and these patients are really caught early in their diagnosis. And we used, I don't know if you are familiar, the National Comprehensive Cancer Network treatment guideline is the latest, which gets updated every 6 months. We use that algorithm to really divide patients into the group that they belong. What I'm saying is the NCCN says that if a patient has a node positive, the margin is closed and the size is less than or equal to 5 centimeters, then you have to do chest wall irradiation. And it gives this type of clinical details for chemotherapy, surgery, and other things. This is for mastectomy patients. So in this group, we have 6 African Americans and European Americans and 8 African Americans. So by doing this algorithm, we know exactly on the basis of their clinical condition what type of treatment they should get. And then we can really determine how many of these patients, African Americans and whites, are getting the treatment. First of all, is the physician recommending what proportion of these patients were recommended by the physician to get the treatment? And after that, after the recommended treatment, how many of them are really getting the treatment between whites and African Americans? And we did a qualitative interview, a depth interview, an hour in their home, and also a phone interview to really enrich the information that will not be getting from the medical record review and also from interviewing patients. And we triangulated the data to really get more information. As you can see, African Americans are more younger, and they are less married, and more likely to finish high school. And their annual income is obviously less than 35 is much higher, and no insurance is much higher compared to the white population. The tumor characteristics, as I said before, poorly differentiated is about 42 versus 28, and both negative, which is relevant, ER and PR, is about twice than the whites, which shows you how aggressive the cancer is. HER2 is also an indicator of aggressiveness. HER2 positivity is much higher, about twice in African Americans than whites. And the triple negatives is the most aggressive, because if they are triple negative, there is no chance you can give them hormonal therapy. And the possibility of giving Herceptin, which is for HER2 positive patients, is also eliminated. Limiting the option of therapy in these patients is almost twice in African Americans compared to whites. And the stage is obviously bad. So if you compare the physician recommendation in terms of surgery, there is no difference between the two races. Adjuvant radiation therapy, almost the same. Chemo, you can see almost the same. Endocrine therapy is where you see a difference. Monoclonal, which is more expensive, you see a difference. And so overall, you don't really see much difference. So in terms of physician recommendation, I will say it is a positive thing that we saw this data. But in terms of receipt, after the physician recommended, you can clearly see a huge difference in chemo, a huge difference in endocrine, monoclonal too, and overall. So African Americans are less likely to take recommended treatment as compared to European Americans. That's the message. So, from the triangulation studies, the most important factors for not getting the treatment include distance of facility and transportation related issues. Some of them actually have to move to their daughter house and to their family's house to do this, to get closer to the institutions as they are getting treatment. And it has been a major problem for most of them. Health insurance related things and the way physicians actually treat patients without health insurance. I have a lot of recorded examples on a tape about how health insurance is a major player in not getting treatment. And finally, job related, because a lot of the companies will not really give disability or some kind of break for the patients, and patients, because they don't have enough income, if they don't do their job and their families, it's been really a major problem. So this slide shows you diagnosis delay is about 60% higher among African Americans compared to whites. Surgical delay is even more, about 2.5 times, huge. But we don't see a lot of delay in chemo, but you see about 40% more delay in African Americans in radiation therapy. So I can talk about this study for another 15 months, but I just, because the time is limited, that's why I presented very brief thing for you guys. Thank you.
You want to take questions or comments right now and then go to the next topic? Yeah.
Thank you for the presentation. I'm curious, you mentioned that there's a delay in diagnosis and surgical. Were there different outcomes between the two populations? Because we're hearing more about being less aggressive for certain cases of cancer. So was there also a disparity in death and outcome?
Yes. Yeah, in our study, a delay of about 3 months this is considered clinically important, and that delay is associated with increased or decreased survival. And clearly, it has a great impact in terms of survival and also in terms of recurrence of the illness.
Okay, great. Yeah, you want to jump up and lift up with your microphone?
So you can place this in your pocket. And I'll place this here.
We're going to shift, and Dr. Jacob is going to talk about a vulnerable population, those at risk for living with or at risk for HIV and hepatitis in Middlesex County.
Hi, so thank you for staying till the bitter end, and I'm going to do a quick presentation about scaling walls and an HIV medical home model of global health at home. And so there are 3 objectives. I want to introduce the issue of HIV among persons who are born outside the United States. So I think this conference has focused on everyone going out to do their work, and what we're trying to talk about is the work we do here for the people who are coming in. And I'm going to take a closer look at the Latino population, the Latinos who live with HIV in the US, how they're disproportionately affected by the AIDS epidemic, and then finally discuss the success of a patient-centered HIV medical home approach in caring for foreign-born populations. And that's at Rutgers, we have a federally qualified health center. So just to start, JAMA had an article in 2012 which actually detailed HIV among people born outside the United States. And just briefly, what they showed is that there are 191,000 people during that time period, which is 2007 to 2010, diagnosed with HIV, and of these, 16% were born outside the US. If you look at these by race, among blacks, 10% were born outside the US. Among Hispanics, 42% were born outside the US. And then among Asians, which is a much smaller number, the largest proportion, 64%, of people living with HIV were born outside the US. And if you look at, this is a table from the article that groups regions by transmission category. The largest region of people foreign-born with HIV in the US is from Central America, about 10,000 individuals. And in this region, Mexico ranks first, with the highest number of people living with HIV who are in the US. And overall, what this article was demonstrating is that compared with US-born people diagnosed with HIV, persons born outside the US were more likely to be Hispanic or Asian. And those are two communities that we've been targeting at our health center. So Latinos do constitute a rapidly expanding population of proportion of people living with HIV. And between 2011 to 2015 in New Jersey, we found that the HIV infections declined by about 17% among whites. It declined by 7% among blacks, but it increased by 17% among Hispanics. And this is a slide from the New Jersey Department of Health. If you look at the racial groups on the slide, we see two major disparities. If you look at the larger population is on your left, the population as a whole, blacks comprise 13% of the population, but 49% of HIV diagnoses. Hispanics comprise 20% of the population, but again, 28% of HIV diagnosed individuals. So those two groups in particular have pretty vast disparities. And what I want to do quickly is just talk about a patient who I took care of this past year. So his name is Carlos. He came from Mexico. He's a 45-year-old man, non-English speaking. And he was unable to find a job to support his family in Oaxaca, which is a region of Mexico from whom we see very large groups migrating, particularly to New Brunswick, New Jersey. So he came in 2002 and found his way to our city, where he was working as a dishwasher in a local restaurant. He reported a history of sex with men, and he identified as a transgender. He actually had no medical care for the first 15 years that he lived in the US. And in February of last year, he became so ill that he was admitted at Robert Wood Johnson Hospital, where he was found to have AIDS, tuberculosis, and Kaposi's sarcoma, and within the year developed histoplasmosis. He eventually died a month ago, despite being started on HIV treatment and on treatment for multiple opportunistic infections. And the reason I bring up his case is really to illustrate the fact that Latinos in the US with HIV do have advanced diagnosis at presentation, advanced disease. They tend to come in with very low CD4 cell numbers and have opportunistic infections that many of us in the AIDS epidemic have not seen since for the last 2 decades. So there is an increased morbidity and mortality in this population. And particularly with regard to the region of Mexico, it's estimated there are between 3 to 6 million Mexicans who are living undocumented in the US, and 1/4 of the AIDS cases in Mexico are among people who have spent prolonged periods in the US. So there is an issue that is ongoing, and the migration-related risk factors for HIV infection, there are many that I've listed on this slide, but as you can see, these are the risk factors that really cause a heightened disparity in terms of people presenting late in their stage of disease, whether it's due to linguistic barriers, changes in sexual practices, of course, discrimination, poverty, lack of housing, and underemployment. This is just a cartoon about immigration reform in the United States and the current political climate, which we're all familiar with. And what I want to say about Latino immigrants is that 25% of Latinos with HIV are uninsured, and half of them rely on Medicaid. So there are low insurance levels overall, and that lack of access to medical care is really the root of the problem, because people are presenting late to be tested and presenting late to be treated. So we know that undocumented immigrants in this country are not eligible for federally funded health insurance. Really, they're eligible for emergency care. And the legal non-citizens who are permanent residents still have limited access to health insurance for the first 5 years that they're in the US. So we know overall non-citizens are more likely to be uninsured than citizens. So what I want to highlight, and in this last part of my talk, is really to show you that it's immigrants with HIV and AIDS who ironically have access to medical care, and there's a few ways that they have access. There's a HIV drug coverage program called the AIDS Drug Assistance Program. It's a Ryan White federally funded program. And there is what's known as the HRSA Ryan White Care Act, which is federal funding for people living with HIV who are uninsured and underinsured. Finally, we have federally qualified health centers, which is a center that I work at, and this is again funded by HRSA. And it's a type of center in which we provide care to the uninsured and to migrant populations. So the last part of what I'm going to show you is how we, as a FQHC-based patient-centered HIV medical home, have achieved access to care for uninsured immigrants with HIV. And I've taken these slides from another conference that I had presented at and just updated the data. But where I work is a federally qualified health center. It's operated by Rutgers and Robert Wood Johnson Medical School. We see about 14,000 patients a year in New Brunswick, and the vast majority are immigrants and people who are uninsured. Within our health center, we have a program, which is a Ryan White funded program, and we're also funded through New Jersey state as well as federal grants. We take care of 388 people living with HIV, and we are the largest provider in the Middlesex County, central New Jersey area. So we serve a number of different people from around the world. So if you can see up on the slide, we have 27 different countries represented in our health center, and this is solely among our HIV patient population. The largest, again, is Central America, as we saw in the JAMA article. That's the largest region from which we have people living with HIV. And in terms of risk factors, the majority of our population, HIV transmission was reported as heterosexual. We have a growing number of people who report sex with men who have sex with men as their risk factor, which is at 30%. And if you look at our racial and ethnic composition, that has actually changed over the last decade. Currently, 48% are Hispanic and 35% Black. And as I'm trying to emphasize that the rate of Hispanics living with HIV is growing, and it's growing in our health center. Finally, with regard to insurance, as those demographics have changed, so have our insurance demographics. So we have about 40% who are uninsured, and then 35% with Medicaid, 19% with Medicare. The main point I want to highlight is that our medical visit frequency is quite high. So we are the red line on this graph, and that shows our health center's medical visit frequency, our ability to engage and retain people in care. So 90% of our population are coming to care every 6 months. And that's from 2012 until the present. That's well above the national average, which has ranged between 60 to 70%. And retention in care is important. This is an article that came out in 2016 that really just showed that the interventions which the CDC has been promoting about HIV screening for quite some time are important, but retention in care is the next step. And it is not only in terms of epidemiologic impact, but also a cost-effectiveness impact. And then specifically, this is a Mathematica policy research article in which they looked at strategies for engaging and retaining Latinos in HIV care. And this is bringing me back to my title of Scaling the Wall. So the barriers to linkage and retention of Latino immigrants at an organization level, as you can see depicted on these blocks, and this is a slide I actually borrowed from another a person who's doing research in the area. The issue of lack of language-based materials, lack of Spanish-speaking staff, limited clinic hours for people who are working, who are day laborers, confusing, unwelcoming facilities. So the strategies to address these issues, which are listed in front of you, are actually the strategies that we employ at our healthcare center. And so this is sort of research-proven interventions that we're currently practicing. And what we have is a group of dedicated staff funded by Ryan White federal funding. It includes our medical providers, nurses, but also case managers, patient navigators, data quality staff, and really these people are the ones who are actively engaging and retaining our patients in care. The other barriers that happen more at an individual level are, as you can see, far greater, whether it's substance abuse, lack of transportation, lack of health insurance, immigration status, just the lack of a proper ID, incarceration, stigma, acculturation, mental health issues. And the strategies to address these, whether it's helping people complete insurance paperwork, referral to social services, support groups, health educators, reinforcement of treatment adherence messages. This is really done by our clinic on the level of case management. And so in this graphic, you can see that our case managers are really providing clients with essential needs. So before a physician even writes an antiretroviral prescription, you have case management addressing really the barriers that people have to taking medications every day for their life in order to treat HIV. And as you can see, our success is depicted on this graph, which is in our viral load suppression rate. So 90% of our population has an undetectable viral load. And if you think about the barriers that I showed you on previous slides, that we have a large number of uninsured, people living in poverty, people who don't even have documentation status, and that we can achieve such a high viral load suppression rate is really a testament to I think the intervention and the dynamics of the structure that we employ at our center. So I think it's a true model for care in this population. So in conclusion, 16% of people living with HIV in the US are foreign-born. Latinos are one community of foreign-born individuals who have a disproportionately high and growing rates of HIV/AIDS and opportunistic infections. And HRSA-funded federally qualified health centers and Ryan White programs have the capacity to provide high-quality patient-centered HIV care, which can break down walls that contribute to racial and ethnic disparities within healthcare in the US. And this is just a thank you to the staff that I work with and the Global Health Institute and Rick for organizing this talk. Thank you.
Any questions or comments for Dr. Jacob?
Yes. In terms of your experience, how can this be, and this is pretty phenomenal in terms of what you've been able to accomplish, could that be translated across national borders? And how could others implement that perhaps within a quality improvement paradigm, not just, at our own institutions, but also international?
Yeah, that's a great question. Actually, there's a National Quality Center that's through the Ryan White federal funding stream that exists here in New York City. And they have an international component. So the individual who is dedicated to quality, who actually comes and evaluates sites in the United States, has been traveling abroad, and he has a number of regions he's covered. And when he's come to evaluate our site, he's discussed how he attempts to implement some of this structure in other, and in more resource-limited areas, which is what you're saying. I mean, I think it's a lot simpler when we're in the US and quite tougher when we get abroad. But there is a model that's, I think they're working on, and I think they're trying to evolve and develop further.
to Wen Hua Lu. Dr. Lu, as I said, will talk about a unique or distinct vulnerable population working here in New York City.
Thank you. Before I start my presentation, I have several questions for you so that I can know you better. So how many of you are healthcare practitioners? Okay. How many of you are doing mental health related work? Okay. So how many of you have been working with racial minorities? Asian youth? Asian people who don't speak English at all. Ooh, cool. Okay, so how do you work with them? What's your experience?
We use translators.
Okay. Yeah, did you find that helpful?
Yes, and they're representative in the hospital who cater to that population.
Mm-hmm.
Of,
okay, so you're a physician, right?
Yes.
So how about therapists? If these people, they don't speak English at all.
I don't know that we have therapists specifically.
Right? Yes. And what if they have, they do have these mental health needs, but they don't know how to express them. They don't know where to seek help and where to seek people who can help them. Right? So these are some topics, questions that I'm interested in. So I'm I'm not a physician. I don't have an MD, although I do wish so. Maybe later, when my daughter goes to college, right? Yeah, I could try to, go to the same college with her. But anyway, I'm doing public health research. So I'm particularly interested in racial and ethnic minority children's health, especially those mental health service use among racial minority kids. I'm a Chinese, not a, in a certain way, not a Chinese American per se. So I'm very interested in knowing how Asian American adolescents, they are dealing with the mental health issues in the US. When I look back at the literature, surprisingly, no literature at all. So people think, mental health is a big issue, right? Especially among minorities. But, very few people. But maybe they are interested in it, but there are a lot of barriers in terms of doing research only. So, I think, it's good for me, to start a new research endeavor. At the same time, I feel so sorry for these Asian American kids and their families. So I don't want to fill out this research gap. So that's why, I'm now doing this research on Asian American adolescents, try to understand their mental health care disparities. Okay, so that's about my research. So also want to share with you an anecdotal story. My daughter, she goes to a weekend Chinese school, every week. She hates it. She's 8. Okay, she said, Mom, why do I have to speak Chinese? Why do I have to go to Chinese school? Well, both our parents are Chinese. We speak Chinese, right? So at the end of last month, we were invited to go to a composition competition of of relatively senior grade students. We saw like one essay or one composition by a Chinese student. She wanted to show her thanks to her mom, who works in a restaurant. She said, Mom, she wrote, Mom, thank you so much for working around the clock every day. Thank you so much for taking care of my younger brother and younger sister. I will help you yelling at them. Okay? Surprised at all? Surprised a little bit? But that's a typical picture of some Chinese families, especially in New York. Parents work every day from early 8 in the morning to 12 at night. So they don't have a lot of patience taking care of their kids. So they yell at them all the time. And unfortunately, the kids take them as a typical practice, parenting practice. So neither the parents, the mom or the kid realize that may lead to some negative mental health consequences among the kids. Okay, so that's a true story and a very typical story. Okay, some background information about this research project. So adolescent mental disorders represent serious deviations from expected cognitive, social, and emotional development, and it has a very severe public health concerns in the United States, affecting up to 21% of US adolescents in their lifetime. And it can lead to serious health consequences and also some other social consequences, including academic failure, violence, sexual risk behaviors, self-injuries, substance use, divorce, crime, unemployment later in their adulthood. And it is, most severely, it is the top risk factor for suicide, which is now the third major cause of death among adolescents aged 10 to 19 in the United States. Okay, so and there are extensive disparities in the prevalence and the treatment of adolescent mental health care. So the prevalence of mental health, especially mental disorders, is especially prevalent among racial and ethnic minorities and people of low socioeconomic status. And unfortunately, around over 60% of the adolescents with mental disorders never receive the treatment for their mental health needs. And the lower treatment rates are especially salient among adolescents of lower socioeconomic status. So based on limited data from national surveys, the lowest treatment rate was observed among Asian American adolescents compared with the 40% treatment rate among whites. Less than 20% of Asian Americans actually receive treatments for their mental health disorders. Okay, so there is a huge treatment gap for Asian American adolescents. So for Asian Americans in New York City, at a glance, so Asian Americans represent the fastest growing racial group, not only in New York City, but also in the United States. So there are now 1.3 million Asian American New Yorkers, comprising 15% of the total population. And 25 of them, that's 1 in every 4 Asian Americans, live in poverty, which is the highest poverty rate among all racial ethnic groups in New York City. And Asian American, when we say Asian American, it doesn't necessarily to be Chinese American only. So in fact, there are 16 ethnicities under the big umbrella of Asian Americans, with more than 50, around 50 or 45 languages and dialects. So once I'm a Chinese American, right? But if I go to Chinatown and a person, it's a true story. I was stopped one day, and when I was walking in China, I live very close to Chinatown, FDR Drive. So I was stopped one day on the road. A person, an old lady with a Chinese face, to ask me. I think she was trying to find a place. She asked me using some Cantonese. I don't understand Cantonese at all. So we ended up using English, to show her the way, to the place that she needed to go. So there are a lot of language barriers, right? If you want to deliver treatment to these Americans, and 50% of them are having very limited English proficiency. So even if they have some certain health needs, they don't know how to express them. So again, back to mental health issues. Suicide is now the third leading cause of death for Asian youths, ages 10 to 14, and the second cause of death for those Asians, for those ages 15 to 24. You must have read a lot of news, right, about Asian American high school students committing suicide. That's even getting more common these years. Okay, so for this specific project, my purpose is to understand help-seeking experiences of Asian American adolescents with mental health needs, and we investigate barriers and facilitators for mental health service use among Asian American adolescents, and to provide some recommendations for future mental health service research, practice, and policy. So as I told you earlier, I'm very interested in this topic. I want to see, as a researcher, the first step is always go back to literature. Unfortunately, I don't find a lot of literature. So now it's time for me to create a literature, right? So I want to do some exploratory study. So for this specific research project, I use qualitative interviews with the 3 major stakeholders in the mental health care treatment. One group of stakeholders are the adolescents with mental health disorders, including depression, anxiety, bipolar disorders, and social mutism, which are pretty common among adolescents, and also Asian American adolescents. Then also I did individual interviews with caregivers, mostly their parents, and focus group interviews with mental health care providers, especially those working mainly with Asian American adolescents. So I'm trying to by interviewing them, trying to understand a complete picture of the treatment disparities among Asian American adolescents with mental disorders. So IRB approval was obtained from Rutgers University, and the consent forms were signed before each interview. So most of the kids were under age 18. So I got consent forms from their parents and consent forms from themselves. Okay. So to be included in this study, the adolescents must be Asian adolescents, aged 11 to 18, who are currently receiving or recently dropping off from services for their mental health issues. For example, depression, anxiety, ADHD, and others. And caregivers of Asian American adolescents with current mental health problems. And also clinicians serving mainly Asian American adolescents and families. So I collaborated with a publicly funded, community-based child counseling center in Queens, New York, so because they have like the largest Asian outreach program in the country. So by interviewing clinicians, like in this clinic, and the patients in the clinic, I can get a more culturally sensitive findings. Okay, so for recruitment, I use purposive recruitment because we have, I have very strict recruitment criteria, and the counselor referral. So after the focus group interviews with the clinicians, ask the clinicians to refer their clients to me. And also snowball sampling. So after interviewing one adolescent, I ask him or her if he or she could refer other friends of them to, to participate in this project. Okay, so for data analysis, all the interviews were audio recorded and verbatim transcribed. The interviews lasted 30 minutes to 1.5 hours. Some adolescents, they were just, they have these mental health issues. It's hard enough to get them into this project, not to let them stay a long time. But some kids were very talkative. They're very willing to talk with you, which, the interview lasted like 1.5 hours. So I was happy for that, of course, right? Yeah, so to show our thanks, we have $30 for adolescents and $30 for caregivers. Semantic analysis was done using NVivo 12. So we initiated a project in October 2017. So the IRB will be lasting until December 2018. Okay, so some preliminary findings for now. So far, I have interviewed 50 participants. So altogether, including 16 adolescents, 16 clinicians, and 18 parents. Okay, so for adolescents, the mean age is 16, and over half of them were born outside of the US. Okay, their average years living in, so on average, their years of living in the United States ranges from 1.5 to 9 years. Okay, and for 80 of them, it's their first time receiving mental health services. And the length of their services ranges from 3 months to 3 years. Okay, so on the table, you can see some more information about them in more detail. Okay, and 11 of the 16 were Chinese, and also 3 of them were Bangladesh, and Korean, and Filipinos. Okay, and we have different referral sources, as you can see from here. So most of the kids were referred by their doctors or physicians, and 3 of them were referred by their parents, and 2 by school counselors or teacher. One interesting finding, after I created this table, I noticed that, the kids and parents, even although 10 of them are parent, child, dad, they provided different information as to referral sources. Most of the kids, they say, they were referred by doctors, whereas most of the parents say, my kid was referred by their teachers. So yeah, that's something that just emerged. I'm curious about it as well. So parents, 18 parents altogether. So originally, I was trying to recruit parent, child, dads. But as you can imagine, that's really hard. For those adolescents who are willing to participate in these interviews, their parents are very much against. They still, their attitude, buy-in is still very low. They're still thinking this mental health issue is something that's make them lose faith. So they were not willing to participate. So whereas for those the dads who participate, both of the parent and the child, they are very much buying in the treatment. So I ended up with 10 dads and 18 parents, which means 8 of the parents participated, although their children are not participating For their parents, the mean age is 44. All of them were born outside the US, and 90% of them were married. Their years of immigration ranged from 3.5 years to 32 years. 90% of them were non-English speakers. They don't speak English at all. Okay, and as you can see from the table, so yeah, most of them were Chinese. Yeah, sorry. Yeah, and they were all. Let's see, they were 90% of them, were from low socioeconomic status, and 90% of them are medically, are Medicaid eligible. Their kids are Medicaid eligible. Okay, so as you can see from the last column, the last rows here, yeah, parents mentioned that, most of the kids, okay, so 10 parents mentioned that their kids were referred by school counselors or teachers, whereas only 2 kids mentioned that they were referred by their schools. There might be some, inaccurate information. So for clinicians, okay, I interviewed 16 clinicians so far. So all of these clinicians are bilingual, bicultural, okay, so which means, they can speak Chinese and English at the same time, or Bengali and English at the same time, or Korean and English at the same time. Mean age is 41, and their clinical experience, years of clinical experience ranges from 1 to 21 years. Okay, as you can see from the table. So, yeah, 13% of them, 80% of them are females, and they are, in terms of professional credentials, they are, or most of them are licensed social workers. Okay, so 16 out of the, all of these clinicians work in mental health clinic. 10 out of the 18 clinicians also work in substance abuse treatment clinic. Okay. So some findings, yeah. I'm still analyzing the data. The data are much richer than I expected. So I was able to get a lot of nuanced information. So some emerging themes thus far. One is the sources of stress for Asian adolescents. What do you think are some major sources of stress for Asian American adolescents? Their parents. I agree. Yes. What else? School. Yes. Academic, right? Academic pressure. Anything else? Language. Yes. Okay. These are all correct. Let's look at some major ones. All these are correct, but there are some major ones. The first one that has been mentioned by the clinicians and parents and students altogether are identity confusion and adjustment issues. Okay, so for example, like this boy, he's 17, he was from Bangladesh. He had anxiety and bipolar disorder. He mentioned, I came here 6 years ago. So it's always been, the culture is so different. The culture here is so different than, how I grew up. So it's always pressure on me. After 6 years being in the United States, he's still feeling the pressure of cultural adjustment. And when I asked, if I can invite his parent to participate in this interview, he said, you know what, if you ask them, I will quit. I'm not attending it anymore. And he refused to meet with me in person. I said, I can only do the interview through the phone. I said, okay, thank you. I feel so, well, yes. So, and also another, a clinician who is also Bangladesh, he said, this moral conflict that I want to be religious, the kids, when he was talking about his clients, right? That I want to be religious, I want to follow the religion, but at the same time, I also want to go and party. I want to go out drink like my peers are going. That's just like an ongoing dilemma for him, for the client, the child, who's, struggling with the two cultures, with his own identity, right? So which culture do I belong to? The Bangladesh culture of my parents or the new American culture, right? So this identity confusion and adjustment issues actually are the most prevalent source of stress mentioned by the clinicians and the children as well. Okay, the academic pressure, right? So yeah, there is also the idea of still the model minority. We think of Asian American, you are always like, you achieve straight A's, right? If you get a B, your parents will be crazy, right? So yeah, this model minority issue is a big source of stress. Like for a nation, like when it comes to school, they are expected to get good grades because you are an Asian. Of course, you have to get an A, right? So that's the model minority, right? This model minority myth, what we call the myth, right, is a big source of stress. The family system problem, family, parents, right? So especially for Chinese Americans, there's a new emerging phenomenon, which is what we call the satellite babies. So who are babies being sent back to China and brought back at school age. So most of the Chinese people, especially those who are working in Chinatown, right? They do manual work. They work very busy every day. They don't have time to take care of their kids. So immediately after their kids were born here in the U.S., they were sent back to China, and their grandparents will take care of them. So until they reach school age, they were brought back to the U.S. As you can imagine, right? There are a lot of attachment issues, a lot of identity issues. Okay, then also family parenting conflicts. Yes, almost well, I would not say all of them, but 90% of the kids that I interviewed mentioned about their the conflicts between their parents or the fight between their parents. So my family has a lot of problems, so my parents used to fight a lot. Yeah, so my mom, she thinks she's always right. So she just keeps yelling at me all the time, right? Okay, and the discrimination. Believe it or not, discrimination is still there these days, right? After, we have been fighting for social justice all the time. Okay, so theme 2, some barriers to mental health service use at the adolescent level. So what are some barriers that adolescents think, right? So one is denial or misconception. So several clinicians in the focus group, they mentioned about this misconception, especially around medication use. Like they use one boy, he said, it's the misconception around medication use. When it's just like once you are on medication, you are the next level of crazy. So if you are not taking medication, you are just crazy. Now if you are taking medication, okay, now it's confirmed. Okay, so this misconception. And also the stigma, not surprisingly, right? So, sometimes several clinicians mentioned that, when the clients were talking with their friends, they would refer the therapist as doctors. But in fact, the therapists are not doctors, right? So that's their way of normalizing this mental health service use. So that's kind of stigma. Okay, the concerns and fear, many of the kids who are also having substance abuse or some other behavior disorders, they were afraid that their parents will know about it if they let their parents know that they are using mental health service. Okay, and also labeling, they are afraid that they will go on their school record or any other type of record. Okay, then language gap with their parents, that's actually a big issue. So, it's hard for them to express that they need the service to their parents. They can't even basically communicate in normal conversation, right? Let alone be like, I need professional help in explaining, why I need it, okay? So there's always a communication gap, as adolescents, they grow up, they learn more, they pick up English very, very quickly and easily, whereas their parents, they don't speak English at all. So the communication gap between them get even more huge, okay? Yes, okay, so. Like I told you, right, I got a lot of rich data, so I do want to share with you more, but yeah. Anyway, so to parents, language barriers, not surprisingly, stigma, yes, understandably. The fear is especially salient among Asian American parents. They fear that it will impact on their children's future, on the academic record of their children. So that brought a lot of fear of them. The perceived need, there's no concept of mental health, not to say mental health service, in many Asian cultures. So, yeah. And also the systemic confusion, lack of knowledge. So they don't know, what's the difference between psychologist, psychiatrist, therapist, or even doctor. So that brings another barrier to them. So last thing, the context. So we know, the culture thing is a big one, right? So if I'm working with a racial minority, you all want to know their culture to start with. Okay, so because of their, like one clinician said, one youth said, because of their culture, the parent culture, they don't really believe this kind of thing. Or pre-migration context. So like, for example, if you want to know their mental health, to diagnose, to make a diagnosis, you want to know their pre-migration context, like whether there is social work or mental health before the migrant, or some service accessibility, availability, and affordability in the community. Understandably, be the big barriers, right? Yes, then so what? Right? We know all this information, so what? So one thing to increase the mental health service use among Americans or minority in general is to increase access to one-step coordinated care. So when you are doing doing practicing in primary care setting, so one way is to to make it as a comfortable platform to talk about mental health as well, and building a culture of mental health in Asian communities, increase the capacity of linguistically and culturally competent mental health services. Okay, I'm a researcher. Yes, I do need more research funding. Okay, and more policy support. Right? Especially, we need more policy support for those people who are not insured, who are of low socioeconomic status. It's ongoing. So, yes, I'm getting more and more rich data. So, do hope to share with you more. And, yeah, thank you.
Thank you, Dr. Liu, for that. I'm losing my microphone. Thank you, Dr. Liu. So I think we've seen that there's a lot of common threads. If we don't look into vulnerable populations and their issues, we're not going to be able to help solve their lack of access and their inequity in access to care, treatment, and prevention. So I'd like to, is there a burning comment or a question? I guess I prefaced that a little too much. But I'd like to thank our panel for bringing up these global health at home. Thank you.
And I'd also like to thank all of you for coming and participating and sharing all of your perspectives. So if we can get a picture with you, that would be great. Thank you. Thank you. Dr. Marley.
Okay, everybody. Believe it, this is like almost, this is it. This is the last time I have to talk to you. Committees, thank you for everyone who volunteered. You'll be getting an email probably within the next 10 to 14 days. And if you think of a committee that, oh my gosh, I didn't put my name down, but I really want to do it, please send an email and we'll be sure to get that to you. Manish is going elections.
So you'll be happy to know that the winners won in a landslide. And thankfully, Miss Columbia and La La Land were not on the ballot, so there shouldn't be any gaffes here. But I'm pleased and happy. First, thank you, Bonnie, for what an amazing job you've done as president this year. A big round for Bonnie. She now will be our past president. Stan, I don't know where you are. You just go into the ether, you're just there. Past. And I'm very, very excited. I mean, the team is you all. You all make this special. But I'm very, very excited to have, Christina, where are you? Well, Christina Blum, she won president-elect. So about a hand for Christina. There she is. Congrats. Annalise DeWolf, she will be our vice president. Harry Anderson will be our treasurer. Okay. Sonagard will be our executive secretary. Sagar Galwankar will be our executive director global. And Stan will be our Executive Director for the United States. Congratulations, everybody. It's an outstanding team, but we need all of your passionate help to make next year just as successful. So thank you so much.
Next year is in Philly, in July. Dates to be determined. I'll let Rich have the floor.
All right, this is the award time. So we have 2 awards for our posters, 2 awards for the oral presentations, and then 2 awards, an emerging leader and distinguished leader. So we'll start off with the posters. I can tell you that the judges were very close. The top 4 posters were all less than 1 point between them. And we're talking between the first and second was a 0.3 of a point. So it was all very close. It was very difficult to decide. But we'll start off with the 2 posters. So we'll start off with the most unique poster. That was entitled Improving Emergency Preparedness Among Children with Special Healthcare Needs in the Pediatric Infant Disease Clinic. Oh, you got it. Come on down and get your poster. Okay. The second award for the poster is Best Overall. This was also very difficult, so it's 0.3 points between this one and the next runner-up. But hands down, Best Overall poster is Resident Experience in Gambia, a call for global medicine rotation. And it's Thomas here, Thomas Woda. Okay, he could not be here. He had to present Saturday and go back today. Working hard, I'm sure. But we will make sure he gets the award. And again, congratulations to that group.
All right. We'd be remiss if we didn't mention the 3 runners-up who were behind by very little, and they deserve special recognition. So I'd like to recognize Alice Try for the poster on post-donation survey to assess appropriateness of medical supply donations to Freetown, Sierra Leone, following the Ebola crisis. Round of applause. Very good. And I apologize for any mispronunciations of names. Next we have poster number 18. And these 3 posters were tied in scores, okay? Number 18 is by Nicole Lee, Risky Sexual Behaviors Associated with Human Immunodeficiency Virus Transmission Among Pregnant Ecuadorians. And then lastly, we have, yes, poster number 30. Sokoi, what she said? Teaching BLS in Ghana.
Dr. Aloisio and Dr. Palladino couldn't be here, and I happen to know that the most unique went to Joe Cochran, who is also, I think, working a shift. So that's, if one of his program directors could take that. And then the best overall oral went to Rushnak from SUNY Downstate. Yoo-hoo! I'll give that to you, Mark. Mark, you'll take that one? Okay, all right. I also just want to say that, you know, you get through a lot of levels before you even get to do the oral. So, I mean, it's like, it's a lot of levels up. So it was fantastic. And we had great research this year. And I hope next year we have 10 times more posters than we've got this year. So I'll turn it over to the awards.
Okay. Now for the award for Distinguished Leader for 2018. I'm going to actually introduce the individual who nominated the winner, and that individual will be discussing that individual and go from there. All right. So I'd like to introduce Dr. Zayad Zifri from Rutgers University. Director of the Office of Global Health.
Thanks. So it's my great pleasure and honor to announce the ACAIM 2018 winner of the Distinguished Leader Award to Dr. Richard Marlink. Dr. Marlink has had an exceptional career in international medicine and AIDS and HIV research and implementation. Hopefully his bio will be listed on the website. I'm not going to bore you with a number of publications and the books he has written in the field. But I want to say that his academic accomplishments are only outclassed by his incredible humility and personal kindness. So talking to him, he's the nicest guy. You look at his CV and you just almost want to pass out, or you feel terrible looking at what he has done. So Dr. Marlink is the director of Global Health Institute. He's basically leading the way, trying to break the silos within our own Rutgers institution. As he mentioned in his presentation, there are many, many people within just one university doing global health. So he's actively breaking the silos, getting us all to work together. He's basically a role model and basically inspiring the new generation of students and faculty members to kind of become leaders in global health and invest their career in global health. And he is developing partnerships that are for sure destined to success. So we're very grateful to have him at Rutgers, and he's really an exceptional academic leader, and I'm very proud that he is the winner of the ACAIM 2018 Leadership Award. That was a short speech.
It's in two pieces, so don't drop it because I think it'll shatter all over the place.
All right, and last but not least, we have our award for the Emerging Leader. And to introduce our winner for this award, I'd like to have Dr. Bonnie Arquilla, our immediate past president, to come to the stage. Thank you.
I thought a long time about how I wanted to introduce this person, and because, and I thought about leadership and teamwork and things like that. And one of the things that really came to me was that many leaders lead from the middle of the room. And many leaders lead by being good team members, and they really create a quality of inclusiveness, at the same time excellence. So I was delighted when I heard that Christina Bloom has the Distinguished Emerging Leader Award. I didn't say it name right, but I'm sorry. So congratulations. You can look at her CV online too.
All right, all those awards will be awarded every year, so please nominate next year. Of course, the posters will be judging and the oral presentations will be judging, but the emerging leader and distinguished leader will be awarded every year. So please send in your recommendations, and I pass the mic off.
I've hijacked the schedule. On behalf of the steering committee of ACAIM and the membership, I would like to recognize someone without whom this day, this weekend, and this year in ACAIM would not have been possible. Our fearless and very assertive and very proactive and incredibly organized and enthusiastic Dr. Bonnie Arquilla. I'd like to thank you for your leadership, and we only can hope that we can follow in your footsteps.
So that's it. Next year in Philly, okay?
Thank you all very much for coming. One small announcement, somebody lost a pair of black reading glasses or regular glasses in the other room. Dr. Daniel has them. See her afterwards. Thank you and have a wonderful rest of your weekend. Get home safely.